Hi, I'm Pat Williams. This is another edition of Your Health Matters with Dr. Benjamin Bryant, who is Chief of Staff and General Surgeon for UH County Medical Center. Dr. Bryant, how you doing today?
Oh boy, I can't complain. Can't complain about this weather.
Wow, isn't it amazing?
It's the warmest. It was the warmest November.
Yeah?
You know.
And it's looking pretty good for here.
After, well, my son told me that he checked something that sounded fairly reliable, and we're supposed to be 5 to 8 degrees warmer than average all winter.
I'll take it.
And it's supposed to be a dry winter by comparison. So
Take that too.
it'll be a nice contrast with last year.
Yeah, absolutely. Did you have a good holiday?
Oh, very nice, thank you. Yeah.
Good. Dr. Bryant, I see you have a guest with you today.
Well, we're very fortunate to have Theresa Gierz come out and join us. She is a nurse practitioner with UH's Hospice and Palliative Care program. And this is an issue that sooner or later affects an awful lot of households.
Mm-hmm.
It's a very difficult time when you have a loved one who's ill and who requires fairly constant attention. And we're talking about end-of-life issues, you know, when you have a diagnosis and there really isn't much more that can be done. There's a transition period and it can be very, very difficult. But if you have access to people who know what they're doing and who you can tell that they really care about what's going on, it can be a huge comfort.
Sure.
In those kind of times.
Sure.
And I met Theresa at a med-exec meeting here, I think it was last month, and heard her speak about the program, learned some things that I certainly didn't know about it, and I thought, gosh, you know, this would be something that would be very great for our community to hear. What's available out there, and that when these kinds of things happen, you're not alone and you're not stuck. You know, there's people who can help you. So at this point, what I'd like to do is introduce Theresa, and she can tell you a little bit about her background and tell you about what UH is doing in this area.
Thank you. I'm happy to be here.
We're
like
glad
to have the opportunity to spread the word. UH is definitely committed to care of the community from the beginning of life to the end of life, and want to make the community aware of all the programs that are available. We have hospice at home. Hospice is a end-of-life service. It is mainly a philosophy of caring. Often people think of hospice as a place you go away to, but it's not. It's a concept of caring and comforting. And part of that is the palliative aspect, and palliative care is really easing the struggle of the day-to-day things that go along with having a serious illness. So when you are in the end of the last few months of your life, the hospice team is there to support you and your family. We have specialized nurses that are certified in hospice and palliative care.
Now these, do they come into the home?
They come into wherever you call home. If you live independently with your family, in an assisted living, in a nursing facility, wherever you call home, that is where hospice will come.
So people don't necessarily have to be uprooted and go somewhere else, and they can stay in familiar surroundings.
Correct. And in the past, that's always, you know, people have died in their own homes and surrounded by their family, and most people, when they stop and think about it, that is their choice, is to not end up in that, you know, emergency hospital situation, but to be comfortable in their own surroundings with their family, and hospice makes that possible. Another way we make that possible, if their symptoms arise where normally you would go to the hospital, we come to you to treat those symptoms and keep you comfortable, guide you along what's going to happen and what you can expect.
Gosh, that's fantastic. And so people aren't having to run around and look, what do we do next, and go to unfamiliar places and wait and all of that kind of thing. Most of what is going to be needed can be provided right where you are.
Right, and usually what happens when you hear that it's time for hospice care is you become...
How do you know that time, Theresa?
Generally the end stage of diseases, when you have a serious illness and the treatments are no longer able to cure you, and you find yourself declining. It can be a cancer diagnosis. It can be something like a lung disease or a heart disease that you've had for years, but now you find every few months you have to go into the hospital. You don't necessarily it's something that your physician determines your prognosis.
Yes, this is generally how it works, is that people who have these kind of illnesses didn't get them yesterday.
Right.
Okay, they've had them for quite a while, and they've been going back and forth to the doctor. They've been in the hospital and out of the hospital, and it seems like things are kind of getting worse because the natural history of a lot of these diseases is that they're progressive.
Correct.
Over time they get worse, and then they get worse. And there's consultation with your doctors all the way through this, and they're the ones giving you the information and telling you, okay, well, we can do this test, but what are we going to do with that information? That may indicate that we need to do some big invasive procedure that the person wouldn't tolerate or that the person simply doesn't want. Okay? So there's a lot of dialogue that goes back and forth with the family, the patient, the physician, the nursing service, the hospital, everybody who's involved with the care. And when it starts to look like, well, maybe the humane thing is to not make this person who's not going to recover, maybe it's not the humane thing to just make them endure more and more stuff.
Correct.
Okay?
Correct.
So maybe the right thing to do is to just say, hey, listen, we're going to stop poking you, and we're going to stop jostling you around and dragging you here and there, because it really isn't going to serve any purpose. Why not keep you comfortable and let you have the best quality of life that you can in the time that you have left? And that's a decision that everybody makes together.
Right.
That's not a unilateral decision.
Right, and not only the physician, but a second physician helps to make that decision. And people often get hung up on the insurance benefit because it states that you have a prognosis of 6 months or less, but no one can really determine that.
That's just...
I know. So, I know, isn't that a silly thing? But people do get frightened by that.
Sure, of course, they don't know.
Yeah, and that really doesn't play in. A physician may have 10 patients and 4 of them only lived 6 months and another 4 lived 8 months and the other 2 lived for 2 years. So it's just the end stage of the disease, and when you get to that point where going through all those tests you don't want to have anymore, and like Dr. Bryant said, procedures that often you have worse outcomes having the procedures, or a procedure that will give you information to say you need some type of treatment and you know ahead of time, I don't want to go through that treatment.
Exactly. So
right.
What's the point of doing that?
Right.
Theresa, you mentioned insurance, and that's one of the big things today in the medical profession that stymies a lot of people out there. Say if a person lives year 2, will hospice continue to take care of them?
Yes, as long as you are still in the final stages of your disease, you will be recertified. Medicare and Medicaid, it's a 100% paid benefit. There's no copay for hospice. That includes not only your medicines that are related to your diagnosis, but any medical equipment you may need, if you need oxygen or a hospital bed at home or a wheelchair. Social work visits who come to offer support to you and your family, help you if you do need to make a placement. We do have spiritual care providers, And one other unique thing with hospice is we have a bereavement team, and they follow with your loved ones for 13 months after you pass away.
13 months?
13
That's
months.
amazing.
Whoa.
Yeah.
Wow.
Yeah. Because those first holidays, first anniversaries, those
Oh,
are the
gosh,
tough
they're-
ones.
Yeah, I went through that with my dad.
Yeah. Now, did everybody hear what she just said? Okay, this is 100% covered.
Yes.
So people should not be afraid to pick up the phone when the time comes, because it's not going to impact you financially. You're going to be able to provide the quality of care that you feel comfortable with for your family, and it's not going to kill you financially.
Right, and that
That's
point.
really important to understand that.
And what you said, what you're comfortable with. We do have all these services. We have home health aides that can come and bathe you. We have volunteers that can sit with you so your caregiver can take a break. But the ball is really in your court. You get to decide how much you want, how much service you need. And it's a transition from you're the main advisor in your care rather than the healthcare system telling you that these are the important things you need. You tell us what's important to you, and we try to help you reach those goals. Some people have family events that they want to be able to go to, and they don't know, how am I going to get there? We can help with that. So
That's that's a good point, because I've never had to deal with this, but I'm learning a lot from you today. Like, if a hospice worker has to come to go to a house, are they there all day? Are they there 24/7? I mean, how does that work?
well, that's the limit of hospice. There is that limit that we don't provide 24/7 care. The nurse can come as often as needed, once a week, 5 days a week, depending on, what's going on. The home health aide can come every day if needed. Maybe you only need her to come once a week. But generally, their visits are an hour to an hour and a half.
And I'm sure that you can attest to the fact that in these kind of situations, that is sufficient to get done what needs to get done.
Right, right. And if you're the caregiver and you need a break, you need some help, hospice does offer what's called a respite care, and where your loved one can go into our hospice facility or a local nursing facility to stay for 5 days. If you have an emergency, we had one lady that was the caregiver who broke her leg, and it took a few days to arrange, what are we going to do now? So that's always available. And also 24 hours a day you can call the nurse. So those middle of the night trips to the emergency room are gone. You call the nurse. She can come right to you if need be, or talk you through, if you get stressed. You always have that backup system, that support.
See, and that is huge, because it's one thing to be with your loved one in this situation and have something happen, in the middle of the night or what have you, and be alone and have no idea what to do.
Sure.
It's a very different thing if you know that all you have to do is pick up the phone, somebody who knows what's going on will answer the phone, and usually they can just talk you through it, tell you,
Right.
explain to you what's going on, tell you maybe you need to do this, maybe you need to do that. If it's the sort of thing where nursing is really required at the time, that'll be arranged. I mean, this is a huge, huge comfort to
Right.
people during this time.
I was going to mention that too, Doc, because, and you touched on this, Theresa, it's not only the sick person that is going through a lot, it's the family members that are going through this too.
Sometimes even more so.
Even more so.
Right.
Exactly, because they're hurting. And you mentioned that there is, in the system, help for them as well. So I think that's really cool. I think that's necessary.
Right, right. And one of the things you had mentioned, if you needed 24-hour care, our social workers are there to help you if you need information on how to access, to hire caregivers, or if you're eligible for, there's a lot of support out in the community programs through your insurance, through the state, through the county, if you meet the requirements to provide care in the home. So they're really there to guide you through those issues. How are we going to make this a reality? If, you struggle with who's going to be the caregiver, there's support for that also.
That is tremendous as well. That's a whole different dimension to this. There is a lot out there available through volunteer organizations, through the government, through the city and so on. And the question is, well, okay, but it's like a wilderness. How do you
Right.
how do you navigate that?
Right.
How do you know who to call? How do you know what to ask them? All of that kind of stuff. And if you've got somebody who can help you through that process and sort of navigate it for you, okay, what's that worth? Okay,
Right.
that's
Sure.
huge.
Sure, it is. Now, you're based out of Cleveland? Is that what you're?
We're in all 8 counties. We have different teams for different areas,
Okay.
different counties. We have, east and west. So your team, you will always, well, generally, most of the time, you'll be assigned a specific nurse and social worker, a team to care for you. Of course, in the off hours, the nurses there's an on-call team, so, but there's still the availability to call. So yeah, it's a great program. We often find that people will become so touched that when their loved ones pass and they've gone through the bereavement process, that they want to become a hospice volunteer. And it's not uncommon for most of our volunteers to have experienced having a loved one in hospice before they make that commitment to be a volunteer.
That is really wonderful.
Yeah.
That's what it's all about.
Yeah.
Right.
That's what it's all about. Now, I'm speaking to our producer here a second. My understanding is that Theresa's phone number and the contact information for this program is going to be appearing on the screen. Maybe it already has by now. They work their magic after we're done. But that number is people are going to be hearing this, and they're going to be saying, okay, well, I need to call. I would like to call. And so the number that's going to be appearing is the number they can call, and then they'll be directed where they need to be. Is that right? So this is a point of contact.
Correct. Correct.
All right.
Also, if you have any questions or regarding anything regarding your medical health, Dr. Bryant has a phone number to call. It's right there, 599-7640. And also, I believe they can email you or I.
They can email. Yeah, it's kind of tough to email me, but they can email you.
Yeah, nick1@suite224.net. And I get the questions to Doc, and then he'll answer them on a future
Right,
show.
and this is my office. My staff is aware of what's going on here, and it doesn't matter if these questions are related to anything that I do or not. That's not the point. The point is that we're sort of taking the responsibility for making sure that your questions get answered, that, if we can't answer them, we find the person who can. If and I say this to the community, such as a topic like we're covering today, if there are other topics in this vast world of medicine that would be helpful to you if we covered them.
Let us know.
Yeah, let us know. People that you want to talk to, we can bring people in who know about all these various different things. And just call us and tell us, gosh, it would be great if you did a program about this. Mm-hmm. And then we'll figure out who the right people are, and we'll get it done.
Absolutely.
So please don't have any hesitation about calling.
Doc and I have done this for almost 8 years, and these interviews twice a month for 8 years, and we've always encouraged the public to get involved and to give us ideas, because we're not sure what you actually need to know and what you want to know. So let us know.
Exactly. All right. Well, that's great. So now, you're in towards main campus, or where are you?
Well, I travel all over. I am centrally located.
So if they call that number, and obviously it's going to be something for our area.
Right.
There's a part of your organization that provides services out here.
Correct.
And then you get the family in contact with the appropriate people out here.
Yes.
And then they get a local phone number and all of that kind of stuff, once it gets established, or?
I'm not sure if it's local, but you will get a specific phone number to call us.
I see.
Yes.
So they contact you and they say, maybe we need to investigate this. You pick it up, your staff picks it up from there.
Right.
And then arranges the appropriate visits, and then, okay, I get it. A lot of times this is done from the hospital.
Yes.
When somebody's in the hospital, and that's when this big discussion takes place, that's when the decisions get made, and you will be called in, your team will be called in at the time that the person's still in the hospital.
Mm-hmm.
But it doesn't necessarily have to be restricted to that.
Correct. And if you just want information, you can call just saying you want information, explain your situation. Or you can call saying specifically, my doctor recommended this, and we can talk to the doctor for you if you're not ready to commit, maybe to find out what your background is. Another thing that we have is for people who are not quite at the terminal phase of their illness, but who still need that support, who have chronic or serious illnesses, maybe they're waning, coming to the last few years of their life with those illnesses they've had for a long time, like you said, especially the chronic lung disease and heart disease, is the palliative piece, which I mentioned at the beginning. Palliative is really just easing the burden. When you're going in for, say, cancer treatments, the cancer specialists are focusing on eradicating the disease. They're not focusing on how you're coping at home, how are you getting to your appointments, the side effects of the medicines and the other symptoms you have that may be distressing to you. And the palliative part of care, they do address those. UH is committed to getting palliative care to everyone. We are establishing it in all of our hospitals. You will be hearing more about it in the future. But the piece that I'm involved in is with home care. If people are homebound and cannot get into a facility or a palliative practitioner's office, then we can visit them in their home. We can make recommendations to their physician. Sometimes the hardest thing is getting into the doctor, and you feel you have to call 911, but if you have something set up in advance. We see this especially in the cancer diseases because there's been so many advances in the cancer therapies, so many targeted therapies. It seems like they always have something new to offer, and you don't get the benefit that you would get from all the hospice support. But this way you would get that support through the palliative care. And all the UH cancer centers do have palliative support, but we want it, like I said, to be in all the area nursing facilities. That's up and coming, and to patients. Some people do receive home care for physical therapy, nursing visits, and they may have questions or concerns or want to make plans for end of life, and they certainly can ask for a palliative consult, and the social worker can come to help you talk about what your goals are, what your treatments are. We find that especially in the elderly population, they may have that living will, which is a document that says what you want done if you can't speak for yourself, and who they want to be in charge of making medical decisions. They may have had that drawn up at their lawyer's office with their will, but they haven't really explained to their family what they want, how far they would want to go, or it's more disease specific. Certainly, take for example, something catastrophic happened and you were to end up on a ventilator and they treat you, you get better, you come off the ventilator, but now take that same ventilator situation and you're someone who has a chronic lung disease, you've been on a ventilator before, you don't ever want that to happen again. That may be something specific that you would say, you know, I don't ever want to be on a ventilator, but for the general population, maybe that wouldn't be an appropriate thing. So those are things that you can explore, what is specific to your disease process, what might happen, what might the treatments be. Are those things that if I get there that I would want to have done, want to go through? Another thing that we see is very often people say that, oh no, I have a power of attorney, I know my son will take care of me, my daughter will take care of me. But in reality, if you haven't told them specifically what you want, that's putting the burden on them to decide, well, would mom want to be kept alive with a feeding tube if she couldn't swallow or communicate anymore? If you're looking from their perspective, you know, you're their family member, they want you there as long as possible. They might make that decision rashly, thinking of their need and their love for you rather than what you would want, and you would want, you know, this is time for me to go peacefully and just be supported. So there are a lot of things involved in having those consults with a palliative care specialist that they can guide you through, having those talks with your loved ones, making decisions based on, you know, what your concerns are, and we're there to help with that too. Like I said, right now I do that in people who are homebound and can't go into an office or one of the facilities for a consult.
I cannot emphasize how important what she just described is, okay? I mean, folks, really, this is a situation in which, truly, in which an ounce of prevention is worth a ton of cure.
Can a regular person that's not in hospice care yet talk to a palliative?
Absolutely.
So that those arrangements are made ahead of time?
That's the whole point. And I'm glad you asked that, Matthew. That is the whole point. What we're hearing here, there's a few things. First of all, you can pick up the phone, okay? You don't have to wait for your doctor to pick up the phone.
Correct.
You can pick up the phone anytime you want. Now, these end-of-life discussions among family members can be very, very difficult because it's extremely emotional, and lots of times there are different family members who have different opinions, and I've seen that become destructive, okay? We all have. And sometimes the people who are making the decisions, the people who have the power of attorney or what have you, don't really know what the person wants, might make a decision that they don't want. The point is that those discussions are tough, and if you've got somebody there who's knowledgeable and compassionate and has been down this road, they can help as that discussion takes place so that it's done in a safe way, in a comfortable way. Everybody gets to talk about what's most important to them, and everybody gets to understand what the patient's wishes are. Can't emphasize that strongly enough. So that whole discussion takes place. It's going to be a lot. It's going to work a lot better if that discussion takes place with somebody there who really knows how to handle it. It can save a lot of grief for the family if you do that. And the other thing is that if this does take place in advance, you know, the person involved is still lucid. You know, there's still the opportunity to really discuss this. What'll happen is everybody comes out of that meeting knowing what the plan is, what everybody's wishes are, how everybody feels. And so then, when the time comes, there's already a plan. You're not scrambling around trying to figure things out, and all of the deeply personal concerns that each family member has, everybody knows that's already been addressed, so you're not having to have that very difficult discussion under the gun, which is terrible. That's a place you don't want to go, believe me. That's not a good situation, and all you got to do is pick up the phone well in advance, and the social work people, the nursing people, will guide you through that discussion along with the doctor, so the doctor is part of it too, And then you're all set.
Right.
Then you're ready. See, then if things happen, okay, we've got a structure, and it takes a huge amount of pressure off.
Right.
So this, boy, I'll tell you, nobody likes to think about it, but you don't want to find out about it when you're already there.
Right.
Okay?
Right.
You want to anticipate this and get it set in advance, and that makes everything better for everybody.
Correct.
Theresa, I gotta ask you, does it take a special type of person to do this kind of job? I mean, it's gotta be tough.
Well, it's tough, but it's very rewarding to be able to help. And I think when you've been in the healthcare system and you've seen the bad outcomes, you feel even more how rewarding it is when people get to have the things happen the way that they want
Sure.
to happen.
I know I have a very good friend that's used to work in this profession. She's now in the administration like you are now, but she worked in it, and she said it actually was a privilege and an honor. She told the story of one time a farmer that was close to death asked one more time to drive his tractor around his farm. And she arranged that, and she goes, it was a wonderful experience
Yes.
to go through.
Yes.
Because he was happy, he was smiling, and she goes, that's what it was all about.
Yeah, exactly.
Yeah.
That's a
Exactly.
wonderful story, Pat.
Yeah, that is.
It was touching to me. So, interesting stuff.
Yeah.
I learned a lot today, again, as I always do in these interviews here.
Yeah. Well, I hope that what we said was clear here. This is going to be this show. I think what's it starting next week, Matthew?
Yep, next Wednesday.
Starting next Wednesday. This show will appear again a couple of times a day for 2 weeks, and this is for the future. It's not quite here yet, but what we're going to want to do is actually have these shows on YouTube, and the link available through the UH Conneaut webpage. It'll be
Great.
easy to find. That's not up yet. We're working on it. We're getting there. All right. But if you have any questions about this may stir up a lot of thinking in a lot of. I certainly hope it does.
Yes.
Because
yes.
it can avoid so much trouble, and it can be such a comfort. You'll see Theresa's number you've seen it during the show, and if somehow you lose that or whatever, you have questions, you can call my office, and we'll direct you in the right direction. Okay? Well, gosh, Theresa, it's very, very kind of you to come all the way out here to our town to talk to our people about this very, very important and compassionate service.
Well, thank you so much for inviting me.
All right.
Very good. Until next time, this is Dr. Benjamin Bryant, Theresa, and I'm Pat Williams. We'll see you in next week.
2 weeks.
2 weeks.
2 weeks.